Good morning and welcome to Sign Out with the Professor. I'm Dr. Lewis Hassel and we'll be beginning shortly. So welcome everyone and pleased to have you join me for this session. As I mentioned, I'm coming to you from Budapest where I'm participating in the European Congress on Digital Pathology, which has been a fascinating meeting. And we're going to use some of the tools we've just been talking about at this meeting today to review some of the interesting pathologies in the fallopian tube. So I'm going to switch to my a different screen here and go to the slides. So you should be able to see the slides now, and apologize that the scan here is less than optimal. So obviously this is not a normal fallopian tube because we're not seeing a normal lumen, and yet we see a complex cystic structure and a sort of coiled structure here. And so many times this is the kind of circumstance we get. We get maybe a dilated tube. As it would appear, this is the case where this is fallopian tube type epithelium here, or at least could be. In general, we'd like to see ciliated epithelium, and this does not look particularly ciliated, but it does have a muscular coat. And that's an important feature to be looking for, is the presence of smooth muscle. And so that can help to define the presence of the fallopian tube when you've got smooth muscle. Now we also have here this sort of very convoluted structure here with some admixed glands, and as well as a bit of sort of endometrial type stroma. And so one of the things you sort of encounter quite early on is when is it endometriosis, when is it an endometriotic tumor, versus when is it just fallopian tube where you've got maybe some endometrioid metaplasia or extension. So we have here the luminal part, but we also have areas of probably serosal tissue with fairly characteristic endometrial type glands. Now, why do I say they're endometrioid? Well, a couple of things. One is they're tall cells. You have some degree of proliferative activity, which would raise, concern for possible, endometrial proliferative disease like hyperplasia or even neoplasia. And you have the characteristic endometrioid type stroma. Now, in general, I don't do CD10 stains when I'm looking for endometriosis. But if I have a questionable case or something, I might do that to verify that I've got endometrial type stroma, which your usual subperitoneal stroma will not stain for. And so then the other feature here is, do we want to consider this as being atypical? Well, here's a mitosis, maybe here's a mitosis as well. And so I think there is a degree of proliferative activity here. In terms of architecture, it certainly doesn't make it to the level of being atypical hyperplasia or something of that sort. And so I don't think I would qualify it in that terms or glorify it in that terms as being a truly pre-neoplastic process. But I would be concerned about it because you do see a degree of proliferation here in this. And I think this underscores the fact that, although endometriosis is common and certainly can be present on the fallopian tube and other areas, it is a potentially pre-neoplastic disorder and sets us up for that. Now, should this be called an endometrioid adenofibroma or something of that sort? And I suppose you could make that case because you do have a little bit of fibrous tissue in between these cystic spaces, which look truly endometrioid. Are there other stains or markers that you might use in this situation to more fully define this as being endometriosis? Well, I am a fan of using P16 stains as a means of characterizing endometrioid type of epithelium, but in the setting of differentiating that from tubal epithelium, I don't think that's very reliable because the patterns tend to be fairly similar. And so in this setting of a possible tubal type of lesion, I wouldn't use that. So then looking at this other component over here, we noticed that there was maybe a little bit of mucinous epithelium here. Actually looking at this now, this looks like it may actually be more ovarian here. So I think we have a little bit of ovary with possibly a mucinous cystadenoma. We have a little bit of fallopian tube here, which does have the smooth muscle, I believe. Am I right here? Or am I just pulling your leg? Well, certainly could be. And then we have
striated.
Yeah, it looks ciliated. I agree. And then we also have clear-cut endometrioid type tissue. So assuming this is from the adnexal tissue, we have adnexal endometriosis, probably some fallopian tube here, as well as a little bit of ovarian tissue with a cystic structure that may be a mucinous cystadenoma. So a whole host of different types of pathology here in this first case to consider, and to just introduce a little bit about, how I approach the differentiation of endometrioid versus fallopian tube sorts of things. There's really not a defining stain that defines fallopian tube type of epithelium. And so, we have certainly the serous neoplasms that we identify later on as truly neoplastic, but we really don't use those stains as being the sine qua non of fallopian tube origin. So at least for the time present, as far as I'm aware, there's not a stain that says this is fallopian tube and not endometrium that is available for use. Unfortunately, that's not a question that really becomes an important issue to think about. So let's go on to some more cases and talk about the next case, more recognizable as a fallopian tube. It's clearly a tubal structure. And probably you've got the sense that it's a little bit dilated. Now, obviously, depending on where we section the tube, we can get a very small, 1 or 2 millimeter in diameter lesion or structure, or a several millimeters in diameter structure, as this case, as we get peripherally more peripheral towards the ovary and so forth. And so when you section the fallopian tube in the isthmus, you're going to get a very narrow, small pinpoint lumen, as well as more close to the uterus. Whereas as you become more peripheral, that's where you get a little bit more dilated, more fimbriated, expansile type of lesion. Now, the other thing to notice here at low magnification is there's a lot of blue tissue here. And I think you can see that we have some pretty intense lymphoid inflammation here, a mixture of inflammatory cells here, some vessels, maybe a plasma cell or two as well. And there's a little bit of perivascular clustering. So lymphoma might even be a consideration, along with the more typical inflammatory lesions. And here you can see in these epithelial line spaces and around the lumen that you also have a dense inflammatory process here. And as well, you can see that there is, exocytosis or lymphoid cells out into the epithelial compartment and beyond into the lumen. So while in other organs you might define this as being lymphoepithelial lesions, it doesn't necessarily imply in the fallopian tube that you've got a lymphoproliferative disorder, because this can happen with chronic salpingitis and long-standing pelvic inflammatory disease. But the history here might become important. One thing that might help you to distinguish this from lymphoproliferative disorder is just the nature of how this blue inflammatory process seems to be quite densely associated with the subepithelial space here. And while there's some expansion of the villus structure in the fallopian tube, it's not particularly distorted, a little bit distorted here. And you don't have too much in the way of progression towards a soft tissue mass. But once you begin to see, this sort of extension into or mass-forming lesion of this sort, you might want to consider that possibility. So mucosa-associated lymphoid tumors do occur in the GYN tract, seen in the cervix, occasionally in other organs as well. And in those situations, they often have a perivascular accentuation, which we see a little bit here. But I'm not showing you this as a lymphoma, but I'm just including that in the differential. In fact, this is a case of kind of rip-roaring chronic pelvic inflammatory disease in a patient who had a history of sexually transmitted disease. And as you know, that can set a person up for infertility, as well as other sorts of problems and challenges with their reproductive issues, such as ectopic pregnancy or those sorts of things. Because this kind of inflammatory process, particularly if it becomes more fibrinoid, can lead to synechia or scarring of the tube, hydrosalpinx, poor transit, essentially, of the gametes that set a patient up for potentially developing an ectopic gestation. In terms of kind of board level questions, what are going to be your top considerations in a patient with chronic pelvic inflammatory disease? Well, not infrequently, these are actually polymicrobial, but certainly in terms of the most frequent sexually transmitted diseases that set a patient up for this, coming up with things like gonorrhea or chlamydial disease would be the main things to be aware of. So chronic salpingitis, really a rip-roaring case in a woman with a history of sexually transmitted disease, pelvic inflammatory disease. Feel free as we go along, if you have questions, either to speak up or type them into the chat. And we'll try to deal with those as we go along. Okay, so here's another little case here, and I think this is also listed as a chronic salpingitis, but you can see it has a very different configuration here. We don't have that intense inflammatory process. And so if you previewed this case, you probably picked up that there's sort of an indolent inflammatory process. It's produced some dilatation, but it has a nice association of these sort of open spaces here in the submucosa, which appear to have maybe a little degree of calcification or a little change of refractile nature associated with them. They're somewhat ovoid, and in a few of them, you get a sense that there's a internal structure to them. So we're probably dealing with some sort of a foreign material. This doesn't look like native inflammatory cells and so forth. So did anybody clue in on what these might be? So with this sort of a
Parasites?
yes, they're parasites, Razan, very good. And with this sort of round oval structure, we'd be thinking about some sort of invascular dwelling parasite that is producing eggs that are of this size. And so we don't really see, I think, the truly diagnostic features of this specific egg. But I believe this patient was of Middle Eastern origin and had schistosoma in other organs, and just happened to have this as an incidental finding in a salpingectomy removed for other disease. So no viable eggs remaining here. It's probably been very long standing, but illustrates the fact that parasites don't always know the right vessels to get into in terms of reproduction. At the same time, we usually think of schistosoma as being bladder secreted and so forth. But any of these pudendal vessels and so forth could be sites where you could have the schistosomes developing or living and depositing their eggs. And as you can see here, the predilection is for submucosal spaces where there's the chance that they'll erupt and be excreted or allowed out back into the environment to develop further on the cycle, which is pretty much what happens when these occur in the bladder. So replicating that process and finding them deposited in a submucosal space in the GYN tract sort of echoes what their more normal pattern of deposition and escape into the next phase of their life cycle would be in the urinary tract. So I'm kind of fond of parasites in tissue sections, and I really like that case for that reason.
Quick question, Dr. Hassel.
Yes.
Have you have experience with the structure in the sac called cancerious corpuscle? It looks like that is a structure in the sac that looks like an egg in the eggs of the those parasites. Does that look similar? I know this is an egg with the lateral spine in the schistosoma. That is very characteristic. But is that usually we call it cancerious corpuscle?
Yeah, so I'm not familiar with that terminology. I mean, usually schistosoma mansoni does have that sort of lateral spine, but I didn't see any in here that I felt were sufficiently diagnostic to characterize as that. So aside from the ethnic or geographic origin of the patient, I don't think morphologically I could differentiate the species here. Certainly, schistosoma japonicum is round without an oval without a spine. So if the patient were from a different geographical background, I might just say, well, that's probably what it is, rather than the other. So I don't know if that answers your question or not, but I think that just saying parasitic eggs or schistosoma species would probably be sufficient in terms of diagnostic reporting.
Sure, thanks.
Okay, so another tube, slightly dilated, this one very hemorrhagic. And so, before we make a diagnosis of, hemosalpinx, we need to think about what causes that. Well, certainly the most frequent cause of that is this entity here, where, as you can see very nicely, we have chorionic villi. They're viable, they're present with, cytotrophoblasts, diffuse syncytial trophoblastic cells, as well as the villus architecture. we've even developed to the point where here you can see small vessels within this, these villi, which to me usually says that, this isn't a mole. This is a embryo with a heart. It's got a vasculature, it's got a circulation that it's trying to develop. Now, I suppose you could have a partial mole in this sort of a situation as well, but the presence of vascularized villi, rules out pretty well the concept of a complete mole, even though we have, a very dilated villus here in the middle, with potentially a cistern here with this sort of dilated edematous space. So those are features that I look for in routine, samples, just to sort of verify that I'm not dealing with a mole. That's oftentimes very helpful in just excluding it right off the top of the bat. Now, most often these will implant within the fimbria, or the distal expanded area of the fallopian tube. So that's kind of due to the fact that the stenoses, or the difficulty in transit of the embryo, is more likely to occur in that isthmus and more distal area of the fallopian tube as it leads into the endometrium, or the uterine cavity. So fimbrial or distal fallopian tube as an implantation site is the more frequent location. Now, we don't see a lot here in terms of gestational reaction, but sometimes that may be all that you see in the fallopian tube as an indication, particularly if it's ruptured and so forth out into the lumen. So, being aware of sort of deciduoid changes like these plump cells here can also give you a clue, when you don't have truly diagnostic villi. So what do we do when we get an ectopic or a presumed ectopic and we just have clot? They've just evacuated all this clot and they're thinking it's an ectopic pregnancy. Maybe there was a slightly elevated HCG or something, but we don't find on our first sections any evidence of villi. So there's, I think, a couple of approaches that people tend to take in that circumstance, depending on whether you are whether you want to put the effort in at the time of gross evaluation or at the time of microscopic evaluation. I think you owe it to the patient to identify villi if they are present. And so there are two ways to do that. One is to go back to the gross specimen and look carefully, because very often, if you are assiduous, you can identify the villi amidst the clot, and then selectively submit that kind of tissue that looks slightly different than the hemorrhagic clot around it. And if you're if you want to look at a lot of glass, you want to get on the bad side of your histotechs and maybe your PAs, then just tell them to put the entire specimen through. And then you can look at, 35 or 40 glass slides of blood clot, looking for that rare villus. Whereas I think, if you spend, the same amount of time or perhaps even less looking at the gross sample, 99 times out of 100, I think you'll be able to identify this grossly, because it's very unusual to just have, a single microscopic villus that you're only going to pick up in one section, sort of thing. So ectopic gestation with nice villi with a cistern, but in a case without evidence of it being a molar pregnancy in terms of the vessels being present. Okay, well, so we've covered some non-neoplastic things. Let's take a look or two here and see where we come in terms of beginning to evaluate things for possible neoplasia. And one of the more frequent things that we see these days is the question of somebody who is a family history or has been identified as a BRCA2 or BRCA1 carrier. And so we're asked to do the full evaluation to look for evidence of serous tubal neoplasia. Oops. Here. And so first of all, at low power, you want to be looking for any areas of hyperchromasia, any areas that sort of stand out in terms of slight thickness of the epithelium, or any sort of micromass lesion that might indicate early invasion. And so, things like this might stick out to you, and you'll come down in high magnification, and it'll look, maybe a little bit abnormal. These nuclei seem a little bit clustered together, a little bit more in terms of pleomorphism, maybe some nucleoli, and then other areas that look maybe a little bit better. And so when I see areas like this, then I begin to get concerned that this could be intraepithelial neoplasia. And I will, look a little further to see if I find anything else. But if I'm just seeing stuff like this, I wouldn't do a P53 stain unless I began to see areas that I could truly classify as having some nuclear atypia. And here again, you see sort of nuclear enlargement, filling almost the full size of the cell. It's very, very focal here. But this can be a multifocal disease. And so that's why we do the full sectioning and look very carefully to see what we have been able to identify. I think once you do find something that looks the least bit suspicious, you're obligated to do a P53 stain to identify whether or not this was actually present in terms of a mutation. Now, I think one of the hard problems in this circumstance is differentiating a null mutation from from a wild type pattern. And so in that circumstance, if you come up with a null mutation, you might consider using the P16 stain as a control, essentially for the null pattern, because in serous tubal intraepithelial neoplasia, the P16 will also be strongly expressed, not due to HPV, but due to the alteration in the pathway. So I think this case, as I recall, did turn out to be P16 mutated, but just in these very focal areas here. And it was also P53 mutated. So just a very subtle difference, as you can see here in a few areas, and not a widespread thing. Now, if you're just dealing with a few, cells, you may have difficulty controlling whether or not your immunohistochemical stain is truly going to give you the same area of question if it's a very small area. So you can have sort of microscopic, non-detectable type of lesions as well that represent serous tubal intraepithelial neoplasia. Now, I remember working with new residents on this situation. Very often they would want to overinterpret, and so forth. And I think there is a learning curve here, and it's acceptable to recognize that. And so erring on the side of doing more frequent P53 stains to adjust your eye and sort of adjust your threshold is not a bad practice when you're in that learning stage. Unless, as we hope there are nice teaching sets to help you to do that and without having to spend money on additional stains. And perhaps that's an idea for a project if someone would like to put together such a teaching set of stick cases. Okay, well, let's go on to the next case. And this is a more readily identifiable area where you've got obviously two areas that at low magnification jump out at you as being bluer and more identifiable. And then we've got a few things over here that might bear some additional inspection, as well as what may be going on up here. So if we were to look up here, well, sure enough, this is a patient who had serous carcinoma, and so the diagnosis was not in question, but is it a fallopian tube origin? Well, right here we've got this area of tubal intraepithelial neoplasia, and probably more than tubal intraepithelial neoplasia, we probably have, based on the juxtaposition to these vessels, an invasive carcinoma that is a serous carcinoma. So defining invasion in the fallopian tube is very difficult. And I think you could look at a case like this and go, I'm not totally sure that that's invasive. But you do have this sort of baseline appearance of what this patient's normal fallopian tube and stroma looked like. And here you have changes in both the epithelium and in the stroma, as well as, close approximation to vessels, as you can see here, and probably some extension here into these spaces. So accepting that this type of invasion in this sort of a case could have been due to just disseminated intraperitoneal disease, the presence of this type and pattern of invasion from this type of tumor is certainly acknowledgeable or possible. Now, the second thing to remember here is that, serous carcinoma, high-grade serous carcinoma, and low-grade serous carcinoma, although that's a different topic, is primarily spread intraperitoneally. It is not prone towards vascular invasion or lymphatic spread at an early stage, but it does very readily spread intraperitoneally. And so it's conceivable that even very small lesions like this, or like this one over here, could be the primary nidus of expression of this tumor that with ready access to the peritoneal cavity is allowed to spread far and wide within that space as a neoplasm. And this is, one of the challenges of this disease is that, it's different than many, many other cancers in that regard. And so the therapies that are directed towards it and the way we stage it are based on that altered histology, altered biology of spread that we see with serous carcinoma. So those are a couple of nice examples of serous intraepithelial neoplasia or serous tubal intraepithelial neoplasia carcinoma, and both in the more florid example as well as earlier in that very, very subtle case. Okay, well, let's go on to another case. And this just illustrates, I think, a common thing to be aware of in the fallopian tube. So embryologically, we have the fallopian tube, which has, the stratified, or excuse me, the ciliated epithelium. It has a muscular coat surrounding it, and so forth. But we also have, living in the same area, the remnants of the Wolffian duct. And so this Mesonephric defined rather than Mullerian derived lesion or tumor or structure can also have a little bit of smooth muscle in the wall and have a columnar epithelium, occasionally with cilia, that has made us generally not worry about whether something is Mullerian or Wolffian in terms of derivation. So this could be all fallopian tube with areas that are dilated and areas that are not. Or it could be that we have fallopian tube here, and we have areas of Wolffian duct that are dilated and forming a small adnexal cyst. I sometimes will make the comment that something's a Wolffian-derived cyst, not because I think that's an important diagnosis to make. It has no prognostic significance, other than it does help to remind our clinical colleagues of the embryology that exists in this location and the fact that neoplasms, tumors, masses can derive from other than the primarily Mullerian system. So that I think is justification on occasion to include that in the discussion. Again, there's no specific marker here that is going to give you this diagnosis for sure. But if you wanted to become, sort of, I don't know, hyper about it, you might be able to detect differential expression of things like androgen receptor, or other hormone markers, WT1, and other sorts of things of that nature that might give you some differential clues as to whether something was the same as the fallopian tube or different from that tube. So I say this just because our next case is a true neoplasm here, and we've got a couple of slides of this. As you can see, it's a very blue neoplasm, a very sieve-like pattern of glands. But notice that it has quite a bit of solid tissue here in between. So we have these sort of tubulocystic glands, and then quite a bit of sort of cord-like solid growth in between with these occasional dilated glands. So, I think as you think about the differential here, you might be thinking endometrioid carcinoma, perhaps. You might be thinking serous carcinoma, looks reasonably high grade and so forth. But I think you should also include two other things in this sort of a histologic appearance. One would be the mesonephric derived carcinomas, or the Wolffian duct carcinomas. Well, I say mesonephric-like or mesonephric-derived tumors, and the so-called female adnexal tumor of probable Wolffian origin, or FATWA, as the acronym is fondly used in the differential. And those are interesting entities that are not common, but can be somewhat diagnostically challenging or disturbing if you don't think about them, and it's only discovered when the case goes off to review at an outside institution because the patient's not responding to therapy or some other circumstance like that. So the immunohistochemistry workup would be important, but I think we have some other H&E slides here. We'll just give you another thing. So notice this is fairly well circumscribed. It doesn't have an invasive pattern like metastatic carcinomas per se. And it's got a mixture of sort of macro and micro cystic structures with, again, this sort of in-between solid pattern growth. So we'll take a look at some of the, I've got another slide here, but I don't think I can spend time on that. We'll go to the immunohistochemistries. So here is one stain, and you can see we've got a differential expression here. Our control stain here, I think you can see this is a marker that's picking up some of our nerve fibers. It's picking up some of the vessels here, and we'll just see that. So that's our control, as well as having some expression in the stroma, but not in the epithelium. So if I'm correct here, This is a Vimentin stain. So let's look and see what Vimentin does, as that's a commonly used marker for endometrial type epithelium. And lo and behold, we see that there's a fair bit of staining here in these cells. So here's sort of one vote to say, oh, this could be endometrioid. Here we have another stain. And as we can see here, this is marking the epithelium, not so much, not as strongly, the more solid part here. I believe this is a CK7. No, pan-CK, okay. So it is a cytokeratin positive tumor. And then here we see an interesting pattern. So we see here, again, this differential expression in different areas of the tumor. Some nuclei staining positive, others less strongly, and actually areas where it looks like this the stromal component is almost negative. Check our stain here. This is estrogen receptor. So there's some nice estrogen receptor variability with this tumor. And then here we see what looks like CD10. It's marking the follicles here. We're getting a little bit of staining here in some of the tissues. So maybe we've got some endometrioid type stroma, but it actually looks like it's staining just a few of the cells more than the stroma, more of the epithelial cells. So that's CD10. And here is our PAX8 stain. Let me make sure that that's right. I'm looking at PAX8 here. Oh, this is CK7, excuse me. So CK7 is largely negative. So that's an interesting finding because most endometrioid carcinomas we would expect to be much more strongly positive and diffusely positive. Here there's just kind of patchy positivity. This is our PAX8, okay. So here's our PAX8, and whereas we started off with that Vimentin thinking this might be endometrioid, in fact, we're looking at PAX8. So that's very helpful in this situation because that is a very specific marker, and it helps to exclude almost all of our Mullerian carcinomas that would be PAX8 positive. So we can rule out serous carcinoma. We can probably rule out endometrioid carcinoma with the negative CK7. And we can also rule out mesonephric and mesonephric-like carcinomas, which would also come into the differential here. So where does this leave us? Well, as you probably guessed, this is a female adnexal tumor resembling or a probable Wolffian origin. And here's one additional stain here. This is our P53, which shows a nice wild type pattern in these cells. Well, it's not staining very well. So this would be a case where if you're thinking about serous carcinoma, you know, doing the P16 to make sure that this is not diffusely positive with P16 could be useful. And I think as we get to the edges here, we found a few cells that were positive. Here's a few here. Very weak staining, but I think that this was still wild type. So that sort of presents the key immunohistochemical findings that we're concerned about. The variable staining can be found with CD10, with some of your sex-cord stromal markers like calretinin and Hibin and so forth, WT1, occasional ER, PR variable staining, but generally negative, uniformly negative staining with PAX8. And your GATA3s, those also can be kind of variable as well. TTF1, which is often positive in mesonephric-like cancers, also would be negative. So with that, let's quickly compare it to, let's go on here to the next case. You can come back to these and look at these stains in this regard. So this is another case or tumor in this area. And I've talked about this tumor elsewhere, but this is the contrasting case of a mesonephric-like carcinoma. And again, you can see it has this sort of intermediate-sized glandular tissue. You'd think about endometrioid-type tumors, fairly high-grade nuclei, and so forth. This patient had a disseminated tumor that had been diagnosed as endometrioid carcinoma, but it was because it was PAX8 positive. It was wild type p53, and it had. But the problem was that it was hormone negative. It was negative for ERPR, and you know, you shouldn't see that in a fairly well differentiated endometrioid tumor. Now, it also had these areas where it was becoming a little more poorly differentiated, where it was becoming sort of infiltrative, almost sarcomatoid appearing type of pattern in these areas with these very narrow cords of cells infiltrating through a somewhat myxoid and fibrous stroma. So in contrast, this case was positive with see which marker this is here. This is our WT1, so it's not a serous carcinoma. We'll go on to the next one. Here is, I believe, GATA3. Yes, you can see there. And so if you can think of and remember to do GATA3 when you have a hormone negative, PAX8 positive tumor, you'll pick up most all of these cases. And here you can see this is a nice strong positive in this situation. So that differential of a fatwa versus a mesonephric type or mesonephric-like carcinoma can come up here in the fallopian tube and is an important one to keep in mind. I think that may be my last slide on this. I do have, well, I think we'll stop here because we're at 8 o'clock, and I'll just take whatever questions you want to bring up at this point from our discussion. Anyone?
Thank you so much, Doctor. Actually, I have a question.
Yes. Yeah.
Thank you for the recommendation to do P53 because actually it's a confusing area when we look at the fallopian tube and we see those proliferative areas of the epithelium. Do you think there's any recommendation so we have to look in the case to do P53 or before having this set, this study set, or like anything we can take a second look, or any proliferative we have to do this P53 because actually it's sometimes it's confusing, or any associated cancer or so.
So I think the indication to do P53 is should be when you see epithelial atypia. I don't think I would do P53s on a totally negative fallopian tube that I didn't see something microscopically, histologically that suggested possibility. We know that there is this component of things called P53 signature, where you do get a small strip of mutated epithelium, but that's not a critical diagnosis to make. It's more of an observation that came out of the research setting of a lot of these. And so that's not something that you have to make clinically, because that's not going to change care. But when they do have a tubal intraepithelial carcinoma that's P53 positive, then they're going to follow that patient much more closely for the possible development of ovarian cancer or disseminated carcinomatosis in the perineum and so forth. So that patient will be treated differently. And so that's why 53 in that situation would be very
Okay.
indicated.
Okay.
Good
Thank you
question.
so much.
Yeah,
Thank
good.
In terms of answer that question, I've seen that people perform Ki-67 pair up with P53. Do you think that Ki-67 will help?
I think that is also a fairly common combination, and that can also help to alert you to areas where there's more proliferative activity or atypia as well that should be evaluated. So, these don't come through very, very frequently. And so I don't routinely do Ki-67s per se, but I would not, I wouldn't object to including that in your panel if you were concerned. Another good question. Liana, any questions from you?
Yeah, so far so good. Thank you so much.
Okay. Jennifer, we didn't welcome you in advance, but thank you for joining us. Where are you joining from?
I'm from Louisiana. I'm sorry I was late.
That's okay. That's okay. Well, thank you so much for your questions. And if you have suggestions or other things you'd like us to cover in the coming months, I will just mention that next month we're going to have a guest professor, Dr. Shweta Agarwal from the University of New Mexico, is going to do some head and neck cases. So that should be a very good diversion from our usual intra-abdominal concentration.
Perfect.
That's
All right.
great. Thank you so much.
All right.
Thank
We'll see you
you.
next time.
See you. Thank you. Bye-bye.
Well, thank you. Bye-bye.